Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Feel free to ask questions in the chat box as we go along, and your questions will be addressed. So today we're going to be actually kicking off our June 2024 Cardiology Month with TeleShadowing, where basically we're going to start off with today's session on an introduction to cardiology, basic anatomy and physiology, and also some MCAT considerations and also career pathways in cardiology. So let me see here. Yes, so we're going to be talking about career pathways first, comparing surgery versus medicine, the heart itself, anatomy, physiology, normal blood flow, and also MCAT topics that are very common on the MCAT regarding cardiology. And then we'll be going over a case study and learning a little bit more about different imaging modalities when diagnosing different cardiac diseases. So this is just, again, just an introduction, a tip of the iceberg into what we're going to be learning in more depth throughout this month. So when you Google types of cardiologists, you get many, many different types of responses. It's a little bit confusing for people who aren't really in the realm of medicine. So I wanted to try making it a little bit easier and understanding why are there different types of cardiologists, what are different pathways to getting to becoming one, and so forth. So here are the different types of career paths. So number one, we want to try to differentiate between cardiologists and cardiac surgeons. They are different. So, so what is the difference, you may ask? So cardiologists, they are doctors who specialize in the evaluation, the diagnosis, and the treatment of medical conditions and diseases that affect the heart and its blood vessels. So a couple of common conditions that are treated by cardiologists, like with or without minimally invasive surgical procedures. They treat hypertension, coronary artery disease. They also treat cardiomyopathies, heart rhythm disorders, also congenital heart diseases, which are basically congenital means basically when you're born with or birth defects. A myocardial infarction, which is the scientific term for heart attack, and also angina. And so when a heart problem can no longer be treated by medications or by the conservative therapeutic management, if that's not responding to the problem, then a referral will be made from a cardiologist over to a cardiothoracic surgeon or a CT surgeon. And that surgeon would then perform surgical procedures to address and manage the problem and restore normal function to the heart. So a cardiothoracic surgeon is someone who specializes in the treatment of diseases and medical conditions that affect the organs in the chest cavity. So it's not just the heart, because cardiothoracic, if you're thinking about the thoracic cavity of our bodies also have the lungs in them, for example. So a cardiothoracic surgeon someone who specializes in the treatment of the diseases and medical conditions that are inside the thoracic cavity, in the chest cavity specifically, and also the mediastinum, including the heart and the lungs. So remember, this is why understanding basic anatomy is very important. We need to know what is the mediastinum, where is the thoracic cavity, what does it include, things like that. All right, so let's actually delve deep into comparing exactly cardiologist versus cardiothoracic surgeon. So let's start off with cardiology. Cardiologists, as we've said before, they are mostly specialists that manage cardiac issues outpatient and can also be inpatient. I'll talk a little bit in more depth about that, the inpatient versus outpatient. Remember, inpatient means in the hospital and outpatient means in a clinical setting, outpatient, outside the hospital. They can see patients in the clinic. They can order echocardiograms or electrocardiograms, ECGs. They also perform angiograms and also prescribe and also tend to diagnose blocked arteries and also address them non-surgically. They can basically prescribe treatments to help reduce blocked arteries. They can prescribe antihypertensive medications or blood thinners to help prevent blocked arteries. They also can treat valve diseases non-surgically. So RX just means through prescription, through medication management. They also manage arrhythmias. Someone has a pacemaker, a defibrillator. They are all seeing cardiologists to make sure that it's working appropriately. Cardiologists can also treat heart failure and also transplant patients and manage them after they've had their heart transplant completed or after they've had a pacemaker put in. So to become a cardiologist, you go to college, you're a pre-med, and you apply to medical school, you get into medical school, you do your 4 years of medical school in the US. I wanted to actually point out with this red arrow here. It says here internal medicine residency, but you can also do a pediatric residency for 3 years, and then specialize in cardiology, a fellowship 3 years afterwards. So basically, this means do 6 years of training after medical school. You can either be a pediatric cardiologist, which means that you'd be treating pediatric populations and diseases of the heart, or if you do internal medicine residency, you'll be treating adults and their heart conditions. As a pediatric cardiologist, you're mostly dealing with pediatric congenital disorders. And then you do a cardiology fellowship after the either peds or internal medicine. And then after the cardiac fellowship, the cardiology fellowship, we have the option to do further specializations for another additional 1 to 2 years. But to become a cardiologist, it takes 6 years after medical school. All right. And then cardiothoracic surgeon, like I said before, they perform surgeries involving the heart, the lung, chest vessels, like the aorta. They do heart and lung transplants. You can also see them in the clinic pre and post-op or post-surgery. They manage surgical complications and do a lot of consultations with cardiologists. Also for them, you go to college, medical school, that's the same thing. But what differentiates between a cardiothoracic surgeon from a cardiologist pathway is essentially after medical school, you apply for a general surgery residency and not internal medicine residency. So that's very important to differentiate because you do general surgery residency for 5 years. And then after that, you can do a cardiothoracic fellowship for 2 to 3 years, or you can go directly into an integrated pathway, a cardiothoracic integrated pathway that will take 4 to 6 years. So if you want to be a cardiothoracic surgeon, there are some more options. Basically, you can go to medical school. After medical school, there are two options. Either go down the general surgery route and then subspecialize from there, or already attend like an integrated fellowship if you know exactly what type of surgery you want to pursue. Specifically in the cardiothoracic area, you can actually apply for residency directly through there in an integrated pathway. Now, those are considered much more competitive because there are much fewer spots for those. So now let's specifically talk about the different types of cardiologists. This is something I know I didn't know. It's something we learned in medical school. There are 3 different types of cardiologists. So there's number one, the general. The general cardiologist is basically someone who does all the cardiovascular consultations. They evaluate, diagnose, and develop treatment plans for patients with known or suspected risk of developing cardiovascular disease, like hypertension, for example, that's managed by a cardiologist sometimes. Of course, internal medicine physicians can also manage these illnesses. They also provide acute cardiac care, so they manage patients with acute cardiac conditions. They also do chronic cardiovascular disease management. So they manage patients with chronic cardiovascular diseases such as heart failure, atrial fibrillation or AFib, coronary disease, and also many others. They also perform cardiovascular testing, like they basically look over these test results, like appropriately, they use appropriate types of testing, like what the picture is showing. Do you know what the picture is showing here? What type of test this is?
Yes, this is a stress test.
Yes, exactly. So this patient doing a stress test over here. And so basically, this is a type of cardiovascular test, putting stress on the heart in a controlled environment to see how the heart is doing. Cardiologists also do disease prevention and risk factor control. So, for example, managing cholesterol, LDL, hyperlipidemia. They also try to, of course, control for risk factors. They try to advise patients to avoid certain foods or advocate for certain lifestyle modifications. And these lifestyle modifications we'll be learning at the end of this month on how to practice more preventative medicine instead of reactive medicine. So basically the specific procedures that are commonly done in general cardiology, they order and interpret cardiac studies like stress tests, EKGs, echocardiograms, the procedures like stress echocardiograms, cardioversions. They also do like nuclear and treadmill stress tests, and things like that, really. So really, they manage most cardiology problems, and they refer out to subspecialized cardiologists like invasive interventional cardiologists or electrophysiologists when needed. So that takes us to our next type of cardiologist, a cardiac electrophysiologist. So so basically, if a procedure requires that the cardiologist break the skin, that would be considered like an invasive type of cardiology. So this type of cardiologist is someone who's responsible. They're considered the electrician, you could say. They focus on the heart's electrical disturbances or rhythm disorders. And then you want to look at the next type of invasive cardiologist, that's interventional cardiology. And these are the people, they're considered the plumbers of the heart. And I'll explain this analogy a little bit in more depth. But basically, these are the people who put in the stents of the heart, or stent placement or balloon angioplasties. So again, this is like, for example, like cardiac catheterizations, that's done by an interventional cardiologist. So again, these are three different pathways of a cardiology fellowship after internal medicine residency. So they can do a cardiac catheterization procedure for diagnosing disease. They can also do percutaneous interventions like angioplasties, stents, other invasive procedures that would consider them to be an invasive cardiologist. So sometimes if you want to go into subspecialties, you require an additional year of training or two outside of the cardiology fellowship. Like in cardiac electrophysiology, if you want to treat the electrical system of the heart, with invasive procedures, then you would need an additional training. Same with interventional cardiology. After the 3 years, you can do subspecializations. All right, so here are the pathways for cardiothoracic surgeons. So basically, cardiothoracic surgery has subspecialties such as cardiac. Oh, sorry, back a slide. There we go. So cardiothoracic surgery has also has its own set of subspecialties in those 4 to 6 years, like cardiac surgeon, heart transplant surgery, that focuses exclusively on surgeries of the heart and in the replacement of a diseased heart with a healthy donor heart. And also general cardiothoracic surgery focuses on surgical procedures of the heart, lungs, esophagus, like I said before, and also can also do lung transplant surgery that also focuses on the surgical replacement of diseased lungs with healthy donor tissue, and also congenital cardiothoracic surgery that focuses more so on the surgical procedures for the treatment of structural birth defects affecting the heart and the major blood vessels that arise from it. Cardiothoracic surgeons, in most cases, they receive a referral from a cardiologist, like a general cardiologist, or even an EP or an interventional cardiologist. Pulmonologists can also do referrals to them, gastroenterologists, etc. Like when surgical procedures are the only treatment option that remain or are available or left for the management of disease. Or medical condition. So cardiothoracic surgeons, they perform open heart surgeries or open surgeries where the chest cavity is basically opened completely. That's how you know that's cardiothoracic surgery. That's what their training is. Cardiologists would not be able to do that. That's literally that's their training mostly in the OR. That's why you usually go down the general surgery route in cardiothoracic surgery. So they do like artery bypass grafting, heart transplants, valve replacement surgeries, lung transplant surgeries, surgeries to correct like birth defects and so on. So in practice, the CT surgeons or cardiothoracic surgeons and their services with patient interaction are a little bit limited, besides the pre-op and post-op period, whereas like for cardiologists specifically, they have much more patient one-on-one face time because the major work with the patient is done during the procedures themselves. And so they can do follow-ups after surgery. Most follow-ups after surgery are done by cardiologists. So it's kind of a cycle, like cardiologists can refer to a cardiac surgeon if they need like a heart transplant, but then that management of the heart transplant will be done by a cardiologist, not by the cardiothoracic surgeon, because the cardiologist's specialty is in medication management. The cardiothoracic surgeon is much more hands-based, much more procedural based. So the cardiologists then monitor the recovery progress, any recurrences or any other complications of the medical problems for which the surgery might have been done. So adult cardiac surgery on the slide that focuses on the heart, including CABGs, a CABG, CABG. You'll hear that a lot. But basically, CABG is a acronym that stands for coronary artery bypass grafting, CABG. They also do valve repairs, replacements, and also aortic surgeries. Thoracic surgeries deal with the lungs, the chest wall, esophagus, and also like lung cancer, resections, and esophageal surgery. Congenital heart surgery addresses heart defects present at birth, both in children and adults. Transplant surgery, as I've said before, focuses on the heart and lung transplant, as well as like the mechanical support devices used for advanced heart failure. So some cardiothoracic surgeons can practice a combination of all of these specialties, but like any practice, usually they focus on one and just get really good at that specific type. And you can see at the bottom, I included a chart here, like the training, if there's like a joint program that you join, like a 4-year general surgery and a 3-year cardiothoracic or integrated, there's different types of training options available for surgery if you already know that you're interested in just treating one part of the body and not necessarily just general surgery. So now let's delve deep into learning a little bit more about the anatomy of the heart. So I like to use this analogy. One second, let me stop screen sharing because my screen just stopped working. Let me share again. One second. There we go. Everyone can see my screen again. So basically, if I wanted to explain the heart, I would like to use the analogy of a house. And inside that house, there are 4 rooms. These 4 rooms are called the chambers. So there are 4 chambers of the heart. They're both upstairs and downstairs. So there are 2 rooms upstairs, 2 rooms downstairs. And I'll explain what are the chambers of the heart later on. But basically, they're the left ventricle, right ventricle, left atrium, right atrium. Then there's also plumbing in that house. They're considered the coronary arteries and also arteries and veins. Then there's the electricity of the house, which encompasses the conduction system like the SA node, AV node, Purkinje fibers. And then there's also 4 doors in this house. They're called the valves, the aortic, mitral, or bicuspid, tricuspid, and pulmonary valves. And so these are the 4 chambers of the heart. You can see here, if you basically cut the heart in half with it like a knife and you just split it, this is basically what it would look like. The left atrium over here, right atrium, right ventricle, and left ventricle. And then here are the valves as well in between these ventricles. So here, I'm going to skip over this video because we're going to have a student talk a
I
little
would like to,
more about.
so you say valves between the ventricles. It's basically the valves between the atrium and ventricle.
Yes, thank you, Dr. Chima. Yes, exactly. So the valves are located between the right atrium and the right ventricle, respectively, and also between the left atrium and left ventricle. So those are 2 valves, and then there's another valve called the pulmonary valve that connects the pulmonary artery to the rest of the heart, and also the aortic valve, which connects from the left atrium to the aorta. And you can also differentiate here between oxygen-rich blood and oxygen-poor blood, and we'll talk a little bit more about that.
Again, Minahal, you said aorta connect from left atrium. No, it should be left ventricle. So aorta is attached to the, so what's the outlet of left ventricle? It's the aorta.
Yes.
It's not to the left atrium.
Thank you, Dr. Chima. Okay, now we'll have a pre-medical student talk a little bit more about.
All right, thank you. So I'm just going to touch on a few of these things related to like the cardiac system that show up on the MCAT usually. So these are just a few things. First, I'll start with blood flow. So we've got blood flow, systole versus diastole, these 2 equations that are helpful in 2 of the sections actually. In the physics section, they show up sometimes, as well as the biochem section. So let me start with blood flow. As Manal was starting earlier. Sorry, let me turn my camera. Okay. So first up, so let's review the blood flow of the heart. So basically, we know that we have a bunch of blood circulating in our body. So when we have blood that goes to our tissues or that provides nutrients and oxygen to our tissues, the blood gets deoxygenated. And this blood, we usually represent it as blue blood because, veins, we've imagined them as blue because they have been deoxygenated. So they come in, the blood funnels through the inferior vena cava, which is this down here. It sort of funnels upwards, and then the superior vena cava, which funnels downwards. So this blood comes from the head and the upper body. So the areas above the heart, the blood comes through the superior vena cava, and then the blood from the lower body comes through the inferior, and these are deoxygenated blood. And it comes to the heart because it needs to get reoxygenated somehow and then pumped back to the rest of the blood, so sort of recycled. So this blood comes in through the vena cavae. They come in through to the right atrium. I know it looks like it's on the left, but if you are sort of facing a patient or looking at someone else, this is their right side. So the blood comes into the right side, and this is called the atrium. So the atriums are the first stop for the deoxygenated blood, the right atrium specifically. Now, from the right atrium, the blood flows through the tricuspid valve here into the right ventricle. So this one mnemonic I like to use is since the tricuspid valve is on the right side, you can say tricuspid. That's sort of how I remember it. Now, as the blood goes into the right ventricle, it's still deoxygenated here because there isn't oxygen like sitting in the heart. The oxygen is found in our lungs. So the blood needs to go into the right ventricle and it pumps out through the pulmonary valve into the pulmonary artery. All right. So the blood goes from the right ventricle through the pulmonary artery. See how it goes to the left and to the right because we have two lungs. So the blood can split between the two lungs to get oxygenated. And once the blood circulates through the lungs, through the capillaries inside of the lungs, the blood gets oxygenated through osmosis, or not osmosis, through the diffusion of oxygen into the blood. And now that the blood is oxygenated, it comes in through the pulmonary vein. It comes through the pulmonary vein back to the heart through the left atrium. So it fills up in the left atrium and the blood goes from the left atrium to the left ventricle through the mitral valve, also called the bicuspid valve. So we've got the tricuspid valve here and the bicuspid valve here. And the bicuspid valve is also called the mitral valve. So now once the blood is in the left ventricle, we've transferred, now this blood is oxygenated. So usually in a diagram, the blood would appear red, but it's still blue, but it's fine. So the blood is oxygenated now and it's ready to be pumped through the body so that the blood can circulate the nutrients and oxygen needed to our tissues. So this left ventricle then pumps the blood through the aorta, through the aortic valve, in order to circulate blood in the rest of the body. And then that cycle repeats. So once the blood is dispersed through the body, it gets deoxygenated again because our tissues use up all that oxygen. And then the blood comes back to the right atrium via the vena cava. So one thing I want to mention is that we talked about arteries and veins. So how do we differentiate between like what is an artery and what is a vein? So artery, how you can remember this with a mnemonic, arteries start with the letter A for away. So A is away from the heart. So this pulmonary artery takes blood away from the heart. And then veins are just the other one. There isn't really a mnemonic for that. It's just the opposite of arteries, bring blood back into the heart. So we know that the blood on the right side is deoxygenated, and then the blood on the left side is oxygenated. And the purpose of these valves here, we've got the tricuspid valve and the bicuspid valve, as well as the pulmonary valve and the aortic valve. The purpose of these is to prevent backflow or to stop blood from flowing back because we want everything to move forward and not allow any like gravity or any other forces like that to allow blood to come back. So so that is basically all for the blood flow of the heart, everything you need to know for the MCAT, just in related to this. We've got a bunch of diagrams here, sort of helping you visualize. Notice how the blood is blue here, and then once it gets oxygenated in the lungs, it turns red because it's oxygenated, and then it flows back to the body. It's just a big cycle. You can use any of these images. They're all right. You know, we've got a more word-focused diagram here, and then we've got images. Anything that works for you to help you memorize this or to help you understand it is the best. All right. So next up, I'll talk about systole versus diastole because questions on the MCAT or content in the passages of MCAT sections can ask you to understand the difference between these. So we've all heard of systolic versus diastolic blood pressure. So what is the difference? So diastole is the process of filling. So remember how we said that blood goes from the atrium to the ventricle? So it doesn't just go, it sort of diffuses because of gravity. Notice how the ventricles are down here, the atria are up here. So the process of filling of these lower chambers or these ventricles is called diastole. So that the dub sound of the heartbeat, when you listen to the heart with a stethoscope, that's diastole, that's the sound. And then systole is when these ventricles, notice how they've sort of contracted because they're pushing blood out. That's the process of pumping. So when you pump blood out, that's called systole. And when you fill the ventricles, that's called diastole. Another thing I wanted to mention is that the right, no,
I would
sorry,
like
left,
to I would
yes.
like to add on. So you said diastole is a filling. So basically you can say diastole is the relaxation of the heart and systole is the contraction of the heart. So during relaxation, it fills up, it fills the ventricle. And during contraction, the ventricles pump the blood out. So relaxation, contraction. So diastole and systole. Right, good.
Yes, exactly. So the thing I wanted to mention was that the left ventricle, the muscle is stronger here because notice how the blood has to pump through this much larger artery, which is called the
Okay,
aorta,
what's this muscle called?
cardiac muscle.
Yes, very
Yes.
good. Mhm.
Yes. So the left ventricle does indeed have a stronger muscle because of the fact that it has to pump so with a lot of force to get the blood pumping through the aorta into the rest of the body. So another thing that might come up, I've seen it on a couple of UWorld questions, a little bit in the AMC, is that this capillary network. So one thing, just a couple of things to note here. So veins are less thick than arteries. So that sort of makes sense because arteries have the job of carrying things. It's more important to carry things to the rest of the blood and to the rest of the body and tissues. So this capillary bed, I got it from Jack Weston. Capillary bed is a network of multiple capillaries formed from different, like, notice how they're all connected. They're interconnected because the blood is one continuous cycle. So capillaries connect arterioles and venules together, and they enable sort of the exchange of water, nutrients, oxygen, carbon dioxide, and waste substances between the blood and the surrounding tissue. So capillaries are sort of doing the job of um, spreading nutrients and oxygen through our body. Another thing that
You can
sometimes
say
comes,
exchange.
yes, exchange of nutrients. So hydrostatic pressure is one, hydrostatic versus osmotic. So what's the difference? You might see these terms when you're studying. Hydrostatic pressure forces fluids and solutes out of the capillaries, and osmotic pressure brings this stuff back into the capillaries. So you might notice when you're studying that you have to observe the difference in pressure gradients, because pressure gradients is a pretty high yield topic, because it can be applied to concepts like kidney filtration. So when you've got a gradient of concentration of solutes, you can have hydrostatic pressure and osmotic pressure sort of balancing the concentrations between the capillaries and the outside. All right, so next topic I'd like to mention is these two equations. So let's start with this one. CO equals SV times HR. This is one of the physics concepts that I wanted to mention. So what do these random letters stand for? CO stands for cardiac output, SV stands for stroke volume, and HR stands for heart rate. So cardiac output is sort of this concept that we like to use to combine the factors of stroke volume and heart rate. So what is the stroke volume here? What is SV? Stroke volume is the amount of blood ejected from the ventricle. So how do you find this? We subtract the volume in the ventricle at the end of diastole minus the volume of the ventricle at the end of systole. So again, the stroke volume is the amount of blood that is pumped from the ventricle, and we find this by basically figuring out how much blood we have left over in the ventricle, how much blood we started with, and how much blood we have left over is we subtract those values to find how much blood was pumped. So that's the stroke volume, and that's in terms of liters. So how do we apply this equation? So let's see, this question here is from the AMC QPAX, I believe. Which of the following responses could maintain cardiac output under dehydration conditions that reduce blood volume? So we've got here, it mentions cardiac output and blood volume. We can use this equation, CO equals SV times HR. So let's see here. If we want to maintain cardiac output or keep this the same, and it's telling us that blood volume is in fact decreased, so the stroke volume itself would decrease. How would we balance this out? If one variable decreases, that means the other variable should increase so that cardiac output can stay constant. So we see that in this equation, another thing I wanted to point out was as stroke volume and cardiac output, no, so sorry, stroke volume and cardiac output have a direct relationship, and stroke volume and heart rate have an inverse relationship, which means that if one increases or decreases, the other one would increase or decrease opposite to that. So if we see that the blood volume or the stroke volume decreases, then heart rate would have to increase, and then the cardiac output would stay the same. So which of these answer choices reflects that? It is this B, or sorry, C, an increase in heart rate. Stroke volume decreases, heart rate increases, cardiac output stays the same. So I hope that was an easy way to apply this equation, because it's important in order to truly understand what we're doing and truly make these concepts stick. You've got to apply these to questions and sort of write equations out to make sure they stick in your mind. So the last topic I will be talking about is this last equation. It can also be found in...
I would like
Yes?
to ask you, how much is the normal cardiac output? I'm asking for the numbers.
I'm not sure about that.
Yeah, so cardiac output basically is amount of blood pumped by heart each minute. So it's about 5 liter per minute. So you can say in 1 minute, our heart is pumping about 5 liter of blood. And in humans, normally we can say between 5 to 6 liter per minute at rest, and to more than about 35 liter per minute in athletes during exercise. So you can see how our heart is like a pump, is a cardiac muscle that pumps and this much blood, 5 liter of blood in 1 minute. So, and during exercise, cardiac output increases. So you should keep in mind this number, the 5 liter per minute. This is the normal cardiac output.
Yes, that makes sense that when you look at the equation, because stroke volume is in liters and then heart rate is beats per minute, if you multiply these, you get liters per minute. So that makes sense. Thank you, Dr. Shima.
And why it pumps? So basically heart pumps, so it can pump enough blood to meet the needs of our body, because our body need oxygen, right? So that's the purpose of this much blood our heart is pumping in 1 minute. So it's called cardiac output. Inside, if someone asks what the numbers, it's a 5 liter per minute. Yeah, go ahead.
All right, thank you. In this last equation here, we've got MAP equals CO times TPR. So let's define these variables again. What do these letters stand for? MAP stands for mean arterial pressure. So the MCAT sort of equates this to blood pressure. If you see basically the word blood pressure or just pressure, mean arterial pressure is sort of where your mind should go. And then we've got CO, which is back in this equation, is cardiac output, and TPR, total peripheral resistance, or you could just, sometimes it's just called resistance, stuff like that. So MAP is like just pressure, which is very talked about in the physics section. So MAP and pressure itself have intricate relationships. Like you know about the Poiseuille equation. That equation is pretty mild yield on the MCAT, which you might want to look into that after this session. So CO and TPR, again, they have an inverse relationship. So if one of these increases, that means the other one is decreasing. And then MAP and CO have a direct relationship, and then MAP and TPR have a direct relationship. And one thing I wanted to mention about resistance here, vasoconstriction and vasodilation. So what do these two things mean? Because these terms can be in your passages or can be in your questions or answer choices. So vasoconstriction is the constriction of your veins, vessels, blood vessels. So when they constrict, that means that they're getting smaller, they're getting thinner, and that means that the blood is facing more resistance. Because if you think about it, the walls of the vessels, of the veins, are sort of rubbing against the blood or making it harder for the blood to pump. And you can sort of think about this logically, that if you've ever put your finger on the edge of a hose, you notice that the water sort of sprays out faster because of this this increased resistance that you've put. So vasoconstriction is the constriction of blood vessels or making them thinner. And the vasodilation is when you increase the radius of the vessels or the veins, and these basically, how do vasoconstriction and vasodilation affect pressure? Vasodilation decreases the pressure and vasoconstriction increases pressure. And these can also be thought of in terms of resistance, because if you see that if we increase pressure here, that means resistance is also increased. So that's how you can think about vasoconstriction and vasodilation. So resistance increases, MAP or mean arterial pressure also increases. direct relationship. So our last question here.
I would like to add more numbers here. So as we talk about cardiac output is 5 liter per minute. So do you know what is the stroke volume, the normal stroke volume? Do you know the numbers?
I'm not too
Okay,
sure
it's
about
okay.
that.
I'll explain to you. So, for example, like patient is a healthy man, 70 kilogram, weight is 70 kilogram, and in 70 kilogram normal healthy person, that you mentioned about the end systolic volume. So, first of all, the end diastolic volume, you said how much blood comes from the atrium to ventricle. So, normal end diastolic volume is about 120 ml. And end systolic volume after the systole is about 50 ml. So 120 minus 50 give a difference of 70 ml. So normal stroke volume in a person with 70 kilogram weight is 70 ml. And now I would like to add on the heart rate. So cardiac output you said is equal to stroke volume times heart rate. Normal heart rate. Can you tell me what's the normal heart rate?
Approximately 100 beats per minute.
No, 72. It's 72 beats per minute. So if you put all these numbers, like stroke volume, I told you is as you mentioned, end diastolic volume, that is 120 ml. Difference end systolic volume, that is approximately 50 ml. Difference is 70 ml. So stroke volume is 70 ml and heart rate is 72 normal. So of course there's a range, but I'm just giving you this number, 70 ml. If you put multiply 70 times 72, can you do it right now?
70 times 72 is 5,040.
Yeah, 5,040 ml. So when you make it liters, it will be 5 liters. So that's how the cardiac output is 5 liter per minute. So that I'm putting these numbers, so it will help you to understand these equations, the cardiac output, how cardiac output is 5 liter per minute. Because normal stroke volume in a healthy a healthy person of 70 kilogram is 70 ml. And then heart rate is 72. When we make a multiply, it's about 5,000 ml. So 5,000 ml is equal to 5 liters. So that's how we calculated the cardiac output is a 5 liter per minute. All right, let's move on.
All right, thank you. So we've got this application question here to apply the equation that I just gave you guys, MAP equals CO times TPR. So basically, this was a passage-based question, but we don't particularly need the whole passage. We can just look at the table that it references. So the table here, we've got mean pulmonary arterial pressure, or we can just talk about mean artery pressure by obesity status. So this study sort of looked at the relationship between levels of obesity or classes of obesity and the mean pulmonary artery pressure in these patients. So the question is asking, when combined with data in the passage, which finding alone would be most likely to lead the researchers to conclude that pulmonary vascular resistance is increased in obese subjects? So it's referencing the data in the passage, and I've pulled the data that we need because there might be one or two tables, but you need to sort of focus on what particular data set that you need to follow. So let's look at the trend here. As the class of obesity increases, or as the BMI increases as well, the mean pulmonary artery pressure also increases. So they are directly related. So let's look at our equation here. That means that this variable MAP increases, and it's asking what would lead the researchers to conclude that pulmonary vascular resistance is also increased. So they're asking, if we know that the MAP is increasing, how would they know that TPR is increasing? So we can sort of think of this logically. If this one variable on this side is increasing and this variable is increasing as well, we would want to keep this variable sort of just constant to make sure it doesn't increase too far. And if this decreases, then that means that MAP wouldn't change significantly. So if we're looking for an answer choice that matches this, that cardiac output should stay the same, so that TPR would increase, which leads to MAP increasing. And also, one thing I want to mention, if you see like variables that you're familiar with, when the MCAT asks you questions like this one, it's asking you about the mean arterial pressure and the pulmonary vascular resistance. If you know two of these variables, you're like, I have this equation stored in my mind that I'm familiar with, and it includes two of these variables. It's probably going to ask about this third one. So that means the answer choice would be talking about cardiac output because it gives us two of these other variables. So let's look at our answer choices. Higher heart rates in the obese subjects than in the lean subjects. So heart rate here is not in our equation, and heart rate was in the other one, SV times TPR. So we can sort of rule that one out because let me look at this. So if we increase heart rate, we can sort of combine these two equations. MAP equals CO times TPR, or MAP equals SV times HR times TPR. So if we increase heart rate, that does not let cardiac output stay constant. So we said that cardiac output should stay constant. We can rule out A. And for letter B, similar cardiac output in the obese subjects and the lean subjects. So I like that they mentioned cardiac output because that's the variable I was looking for. And it says similar. So I'd keep B in my top priority here because it matches my prediction. Let's look at the other ones just to make sure we're not missing anything. Decreased stroke volume in the obese subjects relative to the lean subjects. So again, if we decrease the stroke volume, that means cardiac output is decreasing, and that we don't want that. We want cardiac output to stay the same so that MAP can increase with the increased TPR. So we're going to rule out C. We've ruled out A and C. We're thinking about B. Let's look at D. Upregulation of breathing rate in the obese subjects relative to lean subjects. So breathing rate is basically like, we can think of it as heart rate because the MCAT sort of combines these two together. And again, we ruled out A, so we can also rule out D. So the answer we're left with is, in fact, B. So I hope that sort of helped iron out some of the topics that you'll see on the MCAT. There are a bunch of others that can come up, but these are the ones that I've seen the most. So yeah, Manal, you can take it over from here.
All right. So let me ask you, what is the MAP? What is mean arterial pressure?
MAP, the MCAT sort of correlates it with blood pressure.
Yes, I understand. So basically, I was just gonna add on. So MAP, or mean arterial pressure, is the average arterial pressure throughout one cardiac cycle. Now, what is the one cardiac cycle? It's basically the systole and diastole, as you mentioned before, right? Systole is the contraction of the heart. Diastole is the relaxation of the heart when there's a filling of the blood. And systole, contraction, when they push the blood out. So mean arterial pressure is the average arterial pressure throughout one cardiac cycle, and cardiac cycle includes the systole and diastole. And as you can see from you mentioned MAP is influenced by the cardiac output and systemic vascular resistance, and each of which influenced by several variables. I will not go in detail. I just want to give you what is mean arterial pressure. As you know, you mentioned cardiac output and TPR, but you understand what is mean arterial pressure. Basically, is the arterial pressure throughout one cardiac cycle that includes the systole and diastole. And normally, normal MAP is between 70 to 100 millimeter of mercury. And if MAP drops below 60, then there's a concern that there won't be enough pressure to perfuse the vital organs, including the brain. So if on the other side, if the MAP is above 100 millimeter of mercury, the patient may be experiencing the high artery pressure. So we need to find the cause, because it can cause medical problems as well. So that's why we need to understand what is MAP, or what is mean arterial pressure means. All right, yes, let's move on.
All right, thank you, Dr. Chima. Manal, you can take over screen sharing.
Yes, I'll take over screen share. Let's see. Okay, can you see my screen?
Yes.
Okay, now we'll discuss a little bit about echocardiograms and just go over the normal anatomy. Now, basically, I bring up echocardiograms, angiograms, EKGs, or electrocardiogram, just to understand how we're sort of visualizing everything. So an echocardiogram is done to look for heart problems. The test shows how blood moves through the heart chambers and heart valves. So your healthcare provider may order this test if you have chest pain or shortness of breath, and a cardiologist would probably look over it as well. So this is basically a visual of an echocardiogram on the right. You see this GIF here, and this is basically what you see in a POCUS, or point of care ultrasound. And I'll give you a bird's eye view, essentially what it looks like. You can see here the mitral valve is being pointed at, and essentially that there is a thickened valve. If there's a thickened valve, you can sort of visualize these abnormalities and do some more algorithms in order to be able to better see it. So these are great non-invasive ways to image the heart and also minimize like any x-rays. This is not an MRI or CT, it's just like a POCUS that can also perform an echocardiogram in order to be able to see what the heart looks like. and basically look at your blood flow, look at the thickness of all the arteries, be able to visualize it and also measure it. So these are some great technological advancements in order to be able to see your heart and heart flow.
Nahil, can you explain to us on this echocardiogram, the structure, the anatomy? So you mentioned this, the left atrium.
Yes.
So what's the valve between left atrium and left ventricle? You can talk about with the motion one, the one and the echocardiogram. So we have a better visualization and understanding of the anatomy. Where are the valves? Where's the chambers?
Right. So between the left ventricle and left atrium is the mitral valve. You can see here the mitral valve opening and closing back and forth. That valve, remember I called it like a door between the left ventricle and left atrium.
And you can call it as a bicuspid. You can see two cusps. So bicuspid means there are two cusps, and you can visualize this is an echogenic area. So there are two cusps that come to, like, they open it and then they close it. So you can see yes, if you can pause it in the real time periods, you can see we can pause and say, okay, now valve is open, now valve is closed. So that sound is the loop tube, the sound comes. So because the valve opens and closes. Okay, good.
Thank you, Dr. Chima. We really appreciate the supplemental information, of course, with your experiences. And then there's also the aortic valve. You can see here between the between these two chambers. And I'll move on from here. So just a really interesting way to visualize the heart and its blood flow. And now there's also a heart conduction system. Remember before we talked about cardiac electrophysiologists, they work with the heart conduction system because there are electrical signals in our hearts. Basically, the electrical impulse system, it spreads from the sinus node, and there are various different nodes throughout the left and right atria. The sinoatrial node is called the SA node. And so that SA node from the left here, you can see in the right atrium, it spreads throughout the left and right atria, causing the atria to contract and expelling its volume of blood into the ventricles. So that's actually that electrical impulse that spreads from the bundle and branches or the left and right ventricles here as well, that forces them to expel the blood out into the general circulation. So these are other visualizations of the SA node, the AV node, or atrioventricular node in between each of the four chambers. There are also something called Purkinje fibers, which is something that you will learn when MCAT studying. Just a basic understanding. There's also an electric component to the heart is important because, of course, it's a whole specialty based on sort of managing it. And when you think about defibrillators, that's sort of the application of basically treatment in action, because you want to be able to reset the electrical signaling of the heart. That's why you would basically defibrillate someone or shock someone with a certain number of joules. And that's where the application of physics comes in. That's why physics is so important to understand and learn more about. So essentially, with that understanding of the electrical impulses of the heart, there's something called electrocardiogram or ECG, also called EKG in Europe. Basically, an ECG is another simple and non-invasive test that records the electrical activity of the heart. The ECG can help diagnose certain heart conditions, including abnormal heart rhythms and also coronary heart disease like heart attacks and angina. So this is a video I'm going to show you all. Let me make sure that, can you all hear that? Let me see.
An electrocardiogram,
Were you able to hear it?
Yes.
Okay.
or ECG, or the Dutch or German version of the word EKG, is a tool used to visualize the electricity that flows through the heart. An ECG tracing specifically shows how the depolarization wave moves during each heartbeat, which is a wave of positive charge. And the way it looks depends on the set of electrodes you're using. This particular set of electrodes is called lead 2, for example, with one electrode on the right arm and the other on the left leg. So essentially, when the wave's moving toward the left leg electrode, you get a positive deflection, like this big positive deflection corresponding to the wave moving down into the left and right ventricles.
Okay, that was one osmosis video, essentially going over ECG basics, just a very basic understanding. There's a whole entire specialty dedicated to reading EKGs and ECGs. So essentially, there's something called a PQRST wave. We have talked about it previously.
Minahil, I would like to ask you, so what is, you learn during MCAT, what is depolarization? Do you mentioned about the video just showed the
Yes.
depolarization. What is depolarization?
Depolarization is basically the changing of charges from negative to positive.
Yes, good. So basically the cellular depolarization, or we can call it the membrane depolarization, is a process that shifts the electrical charge distribution. So that the cell is less negatively charged compared to the environment. And in other words, during depolarization, the membrane potential becomes less negative. And now the next question is, what is depolarization and repolarization? So EKG basically, these all the waves you can see, PQRS you're going to talk about is depolarization and repolarization. So the movement of the cell's membrane potential to a more positive value is referred to as the depolarization. And the change in membrane potential from a positive to a negative value is referred to as a repolarization. So what happens during depolarization, the inner membrane becomes less negative. So this is you need to understand this concept and what is depolarization and what is a repolarization and what does it mean, the depolarization of the heart. So depolarization of the ventricular cells is a result of the rapid influx of sodium ions through selective sodium channels, and its duration is measured by the QRS interval. Okay, I'm going to stop here. I'm just going to give you an overview of the depolarization and repolarization.
Thank you, Dr. Chima. So basically, ECGs, they show us the electrical impulses of the heart, and you can see on the right-hand corner, you can also see the heartbeat and heart rate because of these specific boxes that essentially give you the relative rates of each type of heartbeat and heart rate. So you can tell very easily if there's a normal, fast, slow, or irregular heartbeat because they're all on the same drawn to scale type of graphs. And now that we've gone over basics of PQRST, essentially based on the type of node that's being stimulated, it causes a different type of peak or spike or change on the ECG itself. So when the SA node impulse travels from the SA node to the walls of the atria, it causes this part of the area to contract, the P part of the PQRST wave interval. When the AV node, when the impulse basically reaches the AV node, there's a delay. And that delay is indicated right here by this purple line here, about 0.1 second over time. And then when the branches carry the signal from the AV node to the heart apex is located towards the top center, that's when you'll see a short dip. And then there's a sudden high, basically this purple area, that this signal spreads throughout the ventricle walls that causes them to contract very quickly. And so that is why there's this large this very sharp and also fast contraction because we're looking at it over time. And so that is basically the basics of PQRST. Now I'm not getting into specifically what does PQRS stand for, but you can see on the next slide, you can compare like a normal EKG versus a heart attack EKG or myocardial infarction. You can see here in a normal EKG and a heart attack EKG, you can see clearly in the bottom one that there is a abnormality from the normal one, a deviation. You can see here that the sharpness of the contractions are not occurring because remember, a heart attack basically means that there is a blockage in one artery and that artery is not able to contract appropriately, and that sort of, you could say, messes up the rest of the electrical signaling if that's not able to happen properly. And so we will go into much more depth in the next 2 weeks in reading EKGs, what the PQRST intervals stand for. So that's why I'm giving you a bird's eye view, but we will be getting into much more detail. So we're just giving you a broad overview. So there are different types of heart diseases. We've talked about coronary artery disease. There are heart infections. There's heart failure, cardiac arrhythmias.
And I would like to add just pretty quick. So the P wave, as you mentioned, it represents the depolarization of the atria and is followed by the atrial contraction. So you can PQRST when we look at the EKG. So P wave, you can say it's the atrial contraction. Do talk about the electrical activity? That's really good, the depolarization. And this is basically the atrial systole extends until the QRS complex
It's 7 o'clock.
start, at which point the atria relaxes. And basically the QRS complex represents the depolarization of the ventricles. So we need to understand P wave is the depolarization of the atria that is followed by the atrial contraction. When there's atrial contraction, blood pumps from the atria to the ventricle. So now we understand the electrical activity as you mentioned from SA node, AV node, what happens? P wave, electrical activity happens, then that means that depolarization is going on in the atria, that followed by the atrial contraction, that is a systole. That systole from atria to ventricle. So atrial systole, when atrial systole extends until the QRS complex starts. So QRS complex starts, what happens to QRS? So QRS complex represents the depolarization of the ventricles. So now you correlate, and that is followed by the ventricle contraction. So now you will correlate the P wave, atrial depolarization, followed by the atrial contraction. QRS is a depolarization of the ventricles, followed by the ventricle contraction. Why we need this? Because blood has to pump from the atria to ventricle, and from ventricle contraction, from right ventricle go to the lungs, and from the left ventricle goes to the all parts of the body through aorta. So this is the brief overview of the PQRS EKG complex.
Thank you,
That's
Dr. Chima. And we'll be going over this in much more detail next week. So thank you so much for the overview. As I was saying, the different types of heart disease, atherosclerotic diseases, cardiac arrhythmias, heart valve diseases, heart infections, and also heart failures. So we'll briefly talk about coronary artery disease. Basically, coronary artery disease is a common term for a type of buildup of plaque in the heart's arteries that could lead to a heart attack or ischemic stroke. So you can see here on the left-hand panel, how I think about it is if that is an artery and that those are little blood cells, it becomes occluded slowly. Occluded is another word. It basically means buildup. There's a buildup of plaque, and if that plaque keeps on building up, there will be a blockage. So when there is a block in the artery, it leads to muscle damage. Again, why do we need blood? We need blood flow because blood carries oxygen to our tissues, and our tissues need that oxygen in order to operate. So without that oxygen delivery that's so vital to our tissue function, that cardiac muscle become damaged. And we learned from our pathology month last month, I mean, that if there is damage in the cardiac tissue, there's no stem cell regeneration to fix that heart. That's why heart attacks are so they can be very deadly, because if it does not get treated fast enough or on time, it can lead to the death of cardiac tissue that's so important, and it can lead to more pathologies and overall cell tissue death. If there's cell tissue death in the heart, your heart will no longer pump.
All right, good. So Minahil, I would like to ask you, what are the two main coronary arteries? So the main coronary arteries that supply the heart. So I think it will be really good if you go over quick blood supply of the heart. So if not, I can explain pretty quick the blood, because the heart anatomy, as you talk about the chambers, there are 4 chambers, right atrium, right ventricle, left atrium, left ventricle. So the 2 primary coronary arteries that supply the blood to the heart, that is the right coronary artery and the left main coronary artery. And then, of course, they branch out and then becomes other portion like left anterior descending artery, left circumflex artery. I think it was a good, on the next week session, we can add on the blood supply of the heart. Then we have a better idea what we're talking about. So coronary artery disease you're talking about, there's some defect in the coronary artery. So right coronary artery, left coronary artery, and then branches I talk about, left anterior descending artery, left circumflex artery, then posterior descending artery, then there are more small branches. I will not go in much detail. So what happens when these coronary arteries get blocked or get blockage, that called the coronary artery disease. And what happens? So when there's a blockage of the coronary artery, there's no blood supply to the heart, right? So there's, as Minahil mentioning, blockage in the artery, right? So she's explaining over here the healthy artery, how it looks like, and the fatty deposits. So you can see the blood supply over here, but they didn't mention exactly which arteries, but it's okay, you have a better idea. The blood supply of the heart, the coronary arteries, there is some defect in those arteries that causes the coronary artery disease. Let's move on.
Thank you, Dr. Chima. Yes, we will go over that in more depth. The different blood vessels and blood flow. So now I'm going to talk a little bit about the risk factors related to coronary artery disease.
Okay, now I have a question for you. So what happens when there is a blockage in the coronary arteries?
When there's a blockage in the coronary arteries, it can
Mhm.
lead to it can lead to a heart attack or ischemic stroke.
Right. So what is ischemia?
Ischemia basically means there is no oxygen delivery, so tissue death as a result of no oxygen.
Exactly. So ischemia is a basically condition in which a blood flow, what blood carries oxygen. So blood flow that carries the oxygen is restricted or reduced in the part of the body. So in the cardiac ischemia, so what happens in the coronary artery disease? The cardiac ischemia is basically the decreased blood flow and oxygen to the heart muscle. That is called ischemic heart disease. Okay. So it's called coronary artery disease, in other words, called the heart attack, and we can call it acute coronary syndrome as well. So these, we'll talk about the signs of the heart attack as well. So, okay, Mina, let's move on.
Thank you. Yes, we'll be having a session dedicated to heart attacks soon. So basically, the risk factors associated with the coronary artery disease, there are modifiable and also non-modifiable risk factors. So non-modifiable risk factors are things that you can't change, such as your age, your sex, your ethnicity, race, gender, family, or personal history or of coronary artery disease, like family history. It's also modifiable risk factors, basically means that things that you can change with lifestyle modifications, like smoking, diabetes, hypertension can be modified, physical inactivity if one is overweight or obese, and also a high fat or high carbohydrate diet. And the reason why these are important is because basically, unfortunately, cardiovascular disease nearly affects almost half of American adults. So that is a very resounding statistic. And because there are so many people who are still smoking, or 1 in 5 adults, have inadequate exercise or aerobic activity, many people are becoming more and more sedentary, and that's not good for our heart health. And we'll talk a little bit more about that in our fourth session about lifestyle modifications. But by 2035, it's been estimated that by the American Heart Association that more than 130 million adults, or 45% of the US population, will have some form of cardiovascular disease. And that is nearly half of American population just about 10 years from now, 11 years from now, will have some type of hypertension or ischemic heart disease, cardiovascular disease. It's becoming more and more prevalent as a result of poor lifestyle choices. And also many other things like modifiable risk factors, also our diet, the American diet, and so forth. So, another interesting fact that I found that more than half of US adults don't actually know that heart disease is also the leading cause of death or mortality. You can see here on the top left graph that heart disease, while deaths are decreasing overall, whether it be cancers, by strokes, but heart disease is still the #1 leading cause of death in the US. Furthermore, heart disease and stroke statistics, they have when I was comparing this to 2023 update from the American Heart Association, but the 2024 update basically says like that someone in the US is dying of a cardiovascular event every 34 seconds. That is a scary statistic to think about. In just the 1 hour that we've been having this teleshadowing session, in 60 minutes, if you do 60 divided by 60 times 2, that means about 120 people have passed away in the past 1 hour just from a cardiovascular complication. Of course, that's just an estimate. And there are still undiagnosed populations with undiagnosed diabetes. Diabetes is also related to many different cardiovascular complications. We know that the cardiovascular system is very highly interconnected with all of our other systems because it is the matter of our blood flow. So I wanted to also talk about anginas versus heart attacks, because it's related to cardiovascular diseases and CAD or coronary artery disease. So basically, an angina is a type of chest pain that's caused by reduced blood flow to the heart, and angina is actually a symptom of coronary artery disease. So angina feels like squeezing, pressure, heaviness, tightness, or also pain in the chest. It can be sudden or also recur over time. So depending on how severe it is, it can be treated by lifestyle changes, by medication, angioplasty, or surgery. And basically, it's just this angina is a chest discomfort due to insufficient blood supply to the heart muscle, usually due to a blockage in the coronary arteries. It's a sign of coronary artery disease, which means that the person is at risk of having a heart attack. It's not a heart attack yet, but a heart attack or a myocardial infarction, or MI, is when one of the coronary arteries actually clots off and causes damage to the heart muscle itself. This usually causes more intense and persistent pain symptomatically, which oftentimes is accompanied by many other symptoms like nausea, vomit, nausea, sweating, shortness of breath, and that is a medical emergency because there's a blood clot that clots off and that plaque cracks, and that blood clot will just block that artery. If it is a main artery, like a left coronary artery or right coronary artery, we'll see that those are really the main arteries of our bodies. Those arteries branch off to the different smaller arteries that, go to the blood flow of our heads, the blood flow to the rest of our bodies. But this is really a medical emergency. And here I wanted to show you all an angiography. You can see the difference between a normal versus a normal on the left side of the heart and right side of the heart, respectively. So angiographies are used to check the health of your blood vessels and how blood flows through them. It can help to diagnose or investigate several problems affecting the blood vessels, which include like atherosclerosis, narrowing of the arteries, which could mean that you're at risk of having a stroke or a heart attack. You can see here on this slide, you can compare normal versus when there's a blockage here. When there's a blockage here, you will see in an angiography, the dye does not go through, and you can easily visualize it if there is a blockage there. So that's a good, angiographies are a little bit invasive because you do need to inject a dye to visualize if there is blockage or not, but it is a very effective tool in order to be able to tell if there is blockage. Now we're going to talk about a case study very briefly. So basically, this is a case study presentation called CrossFit Chaos. I adapted this from another source. So today we'll be exploring basically a case of a 38-year-old male who presented to the emergency room with severe chest pain during a CrossFit session. So our patient was previously healthy, an active individual who works as a bartender. Recently, he noticed chest pain after increased work hours, which escalated during physical exertion and improved with rest. So you want to remember we talked about collecting a appropriate patient history. You want to ask, are there any alleviating factors? Are there any factors that are aggravating to your symptoms? So I'm talking about here, what alleviated it? Rest. What aggravated it? Physical exertion, this person's symptoms. So this pain that centered in the chest and radiated to his left arm was accompanied by nausea, shortness of breath, and fatigue, progressively worsening over a week. So in terms of medical history, the patient was recently lost 50 pounds on a keto diet, but was previously obese. He has no significant family history as he's estranged from his relatives. Socially, he drinks occasionally and uses marijuana, but does not smoke tobacco. Otherwise, and so you look at the exam, the blood pressure is a bit high in terms of systole. The heart rate is 100, which is a little bit on the higher side, and a respiratory rate 20. Looked uncomfortable with diaphoresis, but otherwise the patient looked normal. And of course, the social history, remember what the patient works as, how often they exercise, and their drinking and alcohol use. So initial labs showed an elevated cholesterol with a concerning lipid panel. The ECG, or electrocardiogram, revealed an ST elevation, and his troponin levels were significantly elevated, which indicated a myocardial injury. Now, we'll talk more about the significance of troponin enzymes in the next lecture, but it's just an example of how we're able to sort of correlate everything that we learned so far, the importance of ECGs, who's looking at it, why they're looking at it. So a normal troponin level is less than 0.04. It's a very clear enzyme that is released when the heart is basically under inflammation, or the heart is basically sending these you can call them like alarm signals out, like Batman signals. So if the troponin is 22, that is much higher. That means that there's indication of myocardial injury or a heart attack. So the coronary angiogram showed here in the right coronary artery that it revealed significant blockages necessitating the placement of a stent in the right coronary artery. You can see here there is no blood flow on the left side, right? So when the stent was put in, then the blood flow was restored because then the vessels were no longer constricted. So who would be doing this? An interventional cardiologist would be putting in the stent. So the rest of the hospital course for the patient, status post-stent in the right coronary artery. Following this intervention, the patient recovered well and was discharged. He did confess to misconceptions about his diet, including the excessive intake of fats like bacon grease, which likely contributed to his condition. This is what keto diets sort of recommend, like increased fat intake. He returned to his fitness regimen a month later with no recurrent symptoms. So this is all not the best thing to do. These are some very popularized keto diets. But you want to think about how this patient had a very young, was pretty young, was in excellent physical shape, but had elevated cholesterol levels, but had a lack of other risk factors that were non-modifiable. Like there was no chronic hypertension, there was no smoking, there was no family history that we knew of, and there was no diabetes mellitus. But there would have been secondary causes of this heart attack, like familial hyperlipidemia or the keto diet that might have caused it, like lifestyle choices. Because familiar HLD or familial hyperlipidemia could be part of this could be part of the cause, the secondary cause, because the high LDL levels and the absence of other risk factors would suggest like a genetic predisposition to cholesterol issues, perhaps. For example, like you can see here, like most seen during cholesterol screens get first degree relatives screened as well, because this is genetic. So it's just an interesting way to connect how cholesterol levels can also affect you. You can also check if someone has this through something called tendon xanthomas, and you can see xanthelasmus eyes and corneal arcus. And also about the keto diet, ketones, as you'll learn in biochemistry, they increase basically, they used to be used for the treatment of epilepsy in 1920s, but because of celebrities using them to lose weight, the diet's popularity does need careful consideration because of the long-term effects on heart health. Because once you switch the body's preferred fuel to ketones instead of glucose, it will basically cause undue stress upon your heart. So remember, not all fats are created equally, and unfortunately, the ketones eventually increase the LDL short term, but increase HDL eventually, and HDL is basically considered. We've talked about this before in previous sessions. HDL is termed the bad lipid. Now that doesn't mean that you should not have HDL. That's sort of a misnomer, but you should have both HDL and LDL, but a little bit more LDL than HDL. There's a specific ratio that goes for that. To talk a little, I will be referencing more stuff from the American College of Cardiology and also the American Heart Association for future sessions. But if you want to learn more about cardiology as a field, want to connect with more physicians from the fields, or learn more about your heart and heart health, and these are some great reputable organizations that you can learn more from. With that said, I'd like to also release a TeleShadowing quiz for today. As always, you'll need a 70% or higher to pass and receive certification for joining. And our next session will also be on cardiology for Cardiology Month, related to cardiovascular diseases and complications. Thank you so much, Erin, for joining, and we look forward to seeing you at our next upcoming session soon. Take care. Bye-bye.